All right. Well, we have a few minutes here to go through some questions for our panel. So let's make good use of our time. I'll start off with Pradeep. Somebody was diagnosed with sleep apnea, and there's been some kind of interaction with glaucoma that's been established in the past. Does that change? Should we be looking for sleep apnea in our patients? And do you think it makes any difference in terms of being treated for sleep apnea with CPAP or some other means?
Yeah, it's a good question. We don't know. And in studies that look at whether, what types of other conditions or other diseases are more common in people with glaucoma as compared to without glaucoma, several studies, but not all, have suggested that sleep apnea is more often found in people with glaucoma. That has led to the suggestion, which is also unproven, that if you treat the sleep apnea, that you might have a better result with your glaucoma. I don't know about that, but there's certainly other things that happen. You can get pulmonary hypertension, you can have cardiovascular disease if you don't treat your sleep apnea. So I think I would definitely do it. I mean, does everybody who has glaucoma need to be evaluated for sleep apnea? I don't think so. I mean, I think you should talk to your doctor and make sure that you don't have any other symptoms such as snoring or wake or daytime somnolence or other issues that would kind of suggest that sleep apnea is present. But I don't think that you necessarily need to go and get a sleep test.
Do you routinely take patients, for example, with normal tension glaucoma and ask them to go to sleep lab or not?
I don't, unless they have any other symptoms suggest it. Yeah, I mean, life is busy and life is full, and so you might have time to do something else besides a sleep test.
Patrick, somebody wants to know, how do you know that you have dry eye? And if they do have dry eyes, when do you kick them to a glaucoma person and say, it's your turn to deal with this issue?
So, in general, if you have any physical symptoms on your eyes that would be related to a foreign body sensation, like there's an eyelash in there, or any redness or fluctuations in vision, or dryness or itchiness, pretty much all of those physical symptoms can be categorized in the dry eye world. Hopefully you're visiting your doctor and they can generally look and see a dry eye. But a lot of times it does come down to what you're actually experiencing. So mention some of those symptoms to your provider. I'm sorry, what was the second part?
So when do you kind of throw up your hands and say, listen, this is a problem that you've got to deal with as a glaucoma specialist? For example, the medications are just too toxic. And
so I generally recommend treating patients in one of two ways. One is if the patient is very symptomatic, I like to treat them because obviously the patient's very uncomfortable. And I also like to treat the patient if I'm seeing signs of dry eye. Sometimes patients won't be very symptomatic. Eyes will look a little bit dry and we might dismiss it during our exam as, it's not too much, we won't talk about it. But generally, I do recommend treating dry eye almost every time that I see it. But of course, if a patient is not terribly symptomatic and there's just mild dry eye on the exam, sometimes our treatments of dry eye can be more of a nuisance than the actual dry eye that you're not symptomatic for, frankly. So I try to make sure that patients are, have dry eye treatments available if that's something that they will benefit from, either from the health of the eye perspective or from the patient's comfort perspective.
is it worth switching to preservative-free drops? And how often does that solve the problem for you?
I think it's sometimes worth exploring. I think mostly that comes down to what I see on the examination and how the patient's symptoms correlate to their drop usage. If you put in drops and your eyes are frustrated and annoying for the next hour or two, sometimes I will blame the drops, and then we might explore maybe a switch to a different one. Or if we started a new treatment on a Tuesday and you had no dry eye symptoms on Monday and all of a sudden you have them on Wednesday, then certainly we have to consider about maybe switching to a preservative-free therapy. And I find it to be fairly successful for many of my.
Aaron, somebody asked about night shift, that there's this whole issue with blue light. And is that something good or is it something bad? And should somebody do that regularly and shifting to that kind of night mode at night? And Is there any downside or upside to that?
So I just want to make sure when in terms of night mode, is that dark mode with that black background with the white writing?
It reduces blue light on phones and
I don't think it harms anything. I don't know if I have strong evidence-based medicine of how much it's actually helping or not, but I don't think it's harmful in any way. In that situation, like I said, I don't think it's causing anything additional. Really, for that one, just as much as I can in terms of enhancing contrast and reducing glare, I find that to be the most beneficial in terms of symptoms of glare sensitivity and those issues.
And Kimberly, somebody asked about, and you gave a really nice presentation about coping, but how do you remain positive and reduce stress when living with a chronic disease that you can't really fix?
Say it again.
So how do you remain positive and reduce stress when living with a chronic disease that you really have no hope of correcting?
That's a really great question that I often get. I think that I'll speak for myself, about 10 years ago, as I was in the throes of losing my eyesight, I remember it was about 11 o'clock at night. I'd put my kids to bed. And I remember just crying and being like, why is it happening? Right? Why is it happening to me? And out of nowhere, and I'm not suggesting this to anybody, this is my own personal experience, that what came to me was, this is happening for you and not to you. And it transformed in a moment, and it really did, how I was going to live my life, right? That while it doesn't necessarily mean that my life is easy, because really none of our lives are easy, so to speak. But it allowed me to have this mindset that I have agency, I have choice. I can choose how I want to live my life with blindness. And I got involved. I am involved, right? I'm involved in the blind and vision loss community, both in aspects like this, where I do a lot of public speaking, but also I do adaptive sports. I race tandem in the Paralympic Open and Paranationals, tandem biking a couple of years ago. I run. I'm involved in crew. I refuse to live a life where my blindness governs how enjoyable my life can be.
So, Kimberly, I'm going to ask you to help us as optometrists and ophthalmologists are dealing with patients have a visual disabling condition, be it glaucoma or otherwise. Is there any question that we can ask that will tip us off that they need help? And how do we get people to seek help if we think they need it?
So repeat the question again.
Is there any one question that you think,
like a patient could?
a provider, a physician, optometrist or ophthalmologist? Is there any one question that can uncover a need for counseling?
Oh, 100%.
And how do we encourage them if they're reluctant? How do we get them to see somebody?
I think regardless of whether or not you're a person with a visual impairment or not, right? I think there is always a question of like, how do you approach? I mean, we all probably have a friend or a loved one. They're like, God, they could really go to therapy, and it's like never a comfortable conversation. But I want to speak to that. The one question a medical provider can ask a patient, and I wish I could see nods because I feel like I'll get one, is, hey, how are you feeling? How are you feeling about all this? Right? I don't think I've ever been asked that as I went through the process of going blind and getting my diagnosis. Oftentimes I go every 3 years, and oftentimes I'm told, I'm so sorry, there's nothing there's nothing out there yet, or don't worry, there's stuff on the horizon. Uh, like, and while the medical provider isn't necessarily equipped to handle the answer, the next piece would be to have resources readily available, right? Professionals that they collaborate with. To feel free to take my suggestions, Wilmer, Will, right? That they collaborate with to help. Okay, because it's a whole system. It's not when you come into an eye doctor, optometrist, or ophthalmologist, or even the low vision specialist, it's not just that one service, right? We are, as humans, we're a whole system. Yeah. We are mind, body, spirit, right? So it's important that we work as a team and collaborate with other providers that can pick up the slack where we were in an expertise that we might not necessarily have.
Thank you.
Sure.
Great tip. Pradeep, somebody wants to know if they're a glaucoma suspect or ocular hypertensive in particular. What's the chance of them going on to developing glaucoma? And is there anything they can do to diminish their risk profile that they can?
I mean, it's certainly a discussion you should have with your provider. There's formal calculators that have been published for people who have ocular hypertension, and you might be able to even find those online, but you would probably need some help filling out all the numbers. But there's well-established calculators that tell you what your risk is. I think it's a much more complicated decision to decide how do you make decisions, even if you know that risk. We kind of talk about glaucoma as a yes or no thing, but as you're hearing, there's people who may have the earliest stages who may be totally asymptomatic. And then there are people who have very advanced disease. And so just because you're going to get it doesn't necessarily mean that you need to treat it or treat it very aggressively. So I think that it's definitely a conversation you need to have with your provider. I think, as we discussed today, that there are some relatively well-proven methods for lowering your eye pressure through behavior. So, if you, it seems to be the things that reduce stress. Yeah, I don't know whether stress is what increases the pressure, but certainly those same things that decrease stress seem to decrease our pressure. So cardiovascular exercise, really getting yourself heart healthy. Meditation is probably something which also reduces a lot of stress as well. Really does seem to lower eye pressure. And so I think that it's a great idea to consider those right now. Sometimes people will ask, well, what exactly do I need to do? And I don't know that we know exactly. But I think that there's a lot of apps out there the Calm app, the Headspace app to guide you on meditation. I think, any type of exercise that gets your heart rate up for 30 minutes, 5 times a week, whether it be a stationary bike or swimming, or walking very briskly. I think any of those are viable options and probably will help reduce your chances of getting glaucoma. None of these are fail-safe, so it doesn't really kind of get you out of still having to see a provider and make sure you're okay. But I think they're things that are almost certainly helpful.
Yeah, somebody wanted to know with meditation, for example, like mindfulness meditation, how much do you do each day and how many times a week? And you can try to answer that, but it's kind of like the exercise, how much is enough to give you a benefit? And those things, I think, are still kind of uncertain, and it varies from person to person, I would think, right?
Yeah, I mean, in the trial they did, it was 21 days of meditation I think they did 15 minutes of deep breathing and 45 minutes afterwards, which is quite a bit. So that's an hour of meditation a day, which is a lot. People have seen benefits of just simply breathing, deep breathing for 5, 10, 15 minutes. So I think that all these things, we don't really know exactly how much you have to do, and that even may differ across people. But start small, start realistic, and oftentimes you start seeing benefits in other parts of your life as well. And then it makes it easy to do more.
Patrick, somebody was wondering if you have untreated dry eye. Can that lead to some serious problems with the cornea or any other part of the eye as a result of that?
Yeah, it certainly can. It really depends on the severity. We don't often think of dry eye leading to major corneal problems when we talk about initial mild dry eye, but severe dry eye that can cause other problems down the road where the cornea can have limited healing if the nerves stop working entirely, or sometimes in eyes, maybe the eyelids won't close all the way and you can have what we call exposure. And that exposure is a sort of a version of dry eye, and that can lead to problems related to scarring. And unfortunately, any of the little rough spots on the eye that are basically an opening in the skin can occasionally lead to infection if some sort of bacteria makes its way in there. So although those are relatively more uncommon side effects of traditional dry eye, those things can happen. So typically, patients who would reach that level are fairly symptomatic and are being treated. That's from a practitioner standpoint, those levels are very hard to ignore or dismiss. So I think working with your provider, if you think you are developing dry eye symptoms or have some element of dry eye, it is better to get to it early, obviously, so you don't progress towards that level of discomfort and potentially secondary problems. But I would say some of those more visually consequential problems are much less common, but certainly real.
Yeah, I'll just throw in, and Pradeep can kind of chime in on this as well. You know, a lot of the glaucoma medications can be toxic to the surface of the cornea, but also the conjunctiva. And we know that with surgery, glaucoma surgery, you have a higher failure rate. If you continue to have kind of chronic irritation, inflammation from medication giving dry irritation on the surface. Pradeep, you want to?
Yeah, absolutely. I mean, I think that, these are things that are additive over time. And, the longer you take these drops, the people have shown that the cells and the conjunctiva, this is the tissue that's over the white part of your eye that produces the mucus layer of your tears, that you actually lose some of those cells over time. So I think years of treatment, especially with preserved eye drops, can cause these problems. I think, as Jay was saying, that there's pretty decent evidence that surgery doesn't work as well. Some of our traditional surgeries in particular don't work as well. And so I think that there's always a fine balance between using drops, which are probably going to be part of pretty much everybody's journey at some point in time, and doing other treatments, whether it be laser or surgery, to try and minimize these drops. And it's a balance that really needs to be worked out and really done very thoughtfully.
So, Aaron, I have two questions for you. The first one's a little bit embarrassing, but how many of the patients that you see for low vision evaluation say, wish my doctor had sent me to you a long time ago?
Yeah. A lot of my patients say that. A lot of times, why has it taken me so long for someone to tell me about you is a common phrase. And in that moment, what I always try to say is, hey, you're in the right place now. And from this moment, we're going to attack, how you're seen and the goals that you would like to achieve. Kimberly brought up this really great, point about, what question to ask. And one of the questions I like to ask is, can you describe to me how you're seen? And that can be helpful for me to kind of get an idea of where they are, because everything on the chart says one thing, or maybe in the exam note will say, oh, they're stable, everything's okay. But hearing it from that patient's perspective is very helpful in helping me determine our next steps. So yeah, sometimes they are a little upset that's taken a while to see a low vision provider, but I always try to just flip it and really confirm that they're in the right place, and we're going to take care of them from that point.
So tell me, there's obviously a need. These patients have a need, and there's certainly benefit in many of the cases, if not all. And the physicians who are caring for them obviously want the patients to be happier and safer. What are the hurdles to getting these folks to low vision specialists? What are the problems with people getting to you?
In particular, I mean, the low vision and the world of low vision optometry, a very, very small niche of optometrists practice low vision. So every optometrist takes a low vision course during their optometric degree, but very few of them actually practice it in their day-to-day practice. So I would say numbers in general is one of the biggest things. There's not a lot of low vision optometrists out there. And then also just finding the providers, we in urban settings, it's actually a lot easier to find the low vision providers, but in the rural settings, a lot of times the closest low vision provider might be 2 hours away, 2.5 hours away. So I would say, just like I said, the number and then the location of them is probably the two biggest hurdles to see them.
Kimberly, I assume that some patients, despite, coaching and various coping mechanisms, still end up needing medications to control their anxiety or depression.
Mm-hmm.
Do you find that to be the case, that, you still have to kind of use medication to get over the hump?
I think that is, it's really it's a person to person experience, I think that, and it's a really, really personal decision. I do think that it can be very beneficial for folks that are moving through really, really hard feelings and emotions and experiences. I usually say medication can help take the edge off. But I and again, maybe get somebody over the hump, but I think that that's a personal person-to-person experience. That's like a conversation with you, the therapist, and then eventually the provider.
Well, along those lines, there are some people that are reluctant to taking any medications because of the concern about glaucoma, because some of them list a concern that you may have problems with glaucoma if you take the medication. So any of the panelists, Pradeep and others, how do you counsel people about that?
I think that, obviously if there are side effects that are going to impact glaucoma, this is not, medication suggesting and this kind of thing is not my area of expertise. But my hope would be, because you have glaucoma and there are medications that might interfere not just with the glaucoma itself, but perhaps maybe some of the other medications you're taking, finding a provider that maybe isn't necessarily your primary care, but actually a psychiatrist who, in an ideal world, would be informed of the fact that there might be some interactions with glaucoma and be able to suggest an alternative medication, because that would be the case in any situation, right? If you're taking medication, you might have, other comorbid types of things going on.
Yeah, I mean, Pradeep, I'm sure that comes up and you can counsel people about that.
Yeah.
Yeah. I mean, a lot of people ask. I mean, I think there's a lot of fear that medications you take may worsen your glaucoma. And there are a few circumstances where that's true, but it's very rare. And, I think a lot of times, one of the ones that comes up is anti-anxiety medicines or antidepressive medicines. And it's a very small number of people who maybe shouldn't take those. The vast majority of people can, especially if they've been under care. So ask, but certainly do not hold back on that very important treatment because you're afraid that it's going to worsen your glaucoma, or especially if you just read the warning signs and you see the word glaucoma there. That's not a reason that you shouldn't be asking the medication. Ask your doctor, and almost certainly you can probably.
So we're getting closer to the reception time. So the last question I'm going to ask here is that somebody wants guidance about alcohol and marijuana use. What's good, what's bad, and I guess some people are self-treating with those agents. So any recommendations there?
It's hard to make a sweeping statement. I think a lot of times the advice I give is based outside of the realm of glaucoma. I mean, with regards to alcohol, I think a small amount of responsible use is a reasonable thing to do, and is not something that you need to avoid. With marijuana, I mean, it's hard to make a generalization about whether people should be using it or not. There's probably some instances where it can be a helpful adjunct for individuals who have chronic pain or anxiety, other issues. But I think nobody should deceive themselves to think that they're actually helping their glaucoma. So try and take that out of the equation and making it.
Well, let's thank the panel. They did a great job.